around, and I don't want that to happen. The other thing that I wanted to mention before we start is I have to be on time as best as I can today because I have to get to a graduation for our residency program. And so I'm going to try to end it as close to about 11:10 as possible. So if I'm not able to answer everybody's questions, if you guys are interested in having like a debrief session after the graduation, all that, or sometime in the week, we can definitely do that once you have more time to think about the case, figure out some questions you have, and go from there. All right, let's get started. So, Dr. Ramya, you're going to get the first snippet of it. So, we have a 56-year-old male with a 30-pack year smoking history and hypertension. So he comes to the ER with worsening abdominal pain over the last 2 weeks. The pain is in the upper abdomen and feels like a pressure and discomfort. So let's take that so far. So what's important in his past medical history?
His past medical history, I think it's important.
Yeah, sorry.
His hypertension.
Okay. Why is that?
And also, because since he has higher blood pressure, it's probably important because of the other symptoms that's going on that he's having.
Okay. So with high blood pressure, you're causing more pressure onto the vessels. You can have narrowing of the vessels. You can have changes in the vessels themselves to deal with that blood pressure. Good. What about the smoking? What does that put him at risk of?
Well, he has a really significant smoking history. So in terms of like at risk, like, do you mean like in this specific case or like just in general?
In general, what does like smoking put you at risk for?
Cancer.
What else?
Damaged lungs.
Damage to the lungs. What else?
Also, like, is his loss of appetite have something to do with the smoking?
Maybe. No, probably not. What else can it cause?
Ulcers.
It can. But so it can cause cancer. It can cause. You had mentioned what was the other thing you mentioned? Sorry.
Damage to the lungs.
Damage to the lungs. Sorry. So COPD. It can cause vascular problems too, right? So it causes. It can help precipitate that atherosclerosis. It can cause that narrowing of the vessels. So all good points to know. And then I say that he has upper abdominal pain. So what's in that area? What can be causing his pain?
In the upper. Hold on. Let me get the notes. Like his stomach, I guess.
His stomach. What else is in that area?
Like liver, kidney, pancreas.
Liver, kidney, pancreas, gallbladder is there too. What else is in that area? Spleen. Good. Diaphragm too. What if I told you that he had upper abdominal pain and back pain?
So I would think more like kidneys.
Kidneys. What if it's like a tearing type pain in his back? What would that be?
I'm not sure.
Okay, good. It can be something like an aortic dissection, right? So in the back, your aorta sits there, and if it's like tearing, it's like dissecting downwards. So good job. So Dr. Lopez, so he has difficulty eating and is getting full easily, and has lost 20 pounds over the last month. Why is that important?
It's important because it could indicate that there's some sort of cancer.
Possibly, yeah. So difficulty eating and getting full easily. What type of cancer would you be thinking of?
More of like stomach cancer.
Yeah. So why would that cause you to have difficulty eating?
Maybe because you're not emptying your stomach as much.
You're not emptying the stomach, maybe, but what else? Why else? If you just think about it logically, why else would that cause the feeling of fullness?
I'm not too sure.
It's okay. So let's say this is your stomach right here. It has a certain volume, right? And so if you have a cancer sitting in there, now it's taking up space. So your stomach can expand, but you have less volume to work with. And so as you eat, the food comes in. You're having more volume being taken up by that food and that cancer, making you get full more quickly. So if you have a big enough cancer and it's a pretty big mass in there, you can have that sensation of being full easily. Good. I think somebody said that there might be a blockage, and that's also true. So if you have the cancer that's closer to like the pylorus and where it empties into the duodenum, you can have obstruction of the outlet, and that can cause an obstruction where the food can't even come out. So you're having food just kind of sitting there and not able to go to the rest of your colon or your GI system. A lot of times it's going to cause a lot of nausea because it'll cause irritation in the stomach, and you'll have vomiting as well. But good. What about the weight loss? He lost 20 pounds over the last month.
I think that would also be a sign of cancer if it wasn't intentional.
Yeah, so the big question is this intentional weight loss or not? So if he's exercising, he's dieting and all that, he's losing 20 pounds, well, good for him. But if he is not, if he's eating normally and he's trying to lose weight, and he's not trying to lose weight and he's still losing weight, that's worrisome. It can be something like cancer. So why does cancer cause you to lose weight like that?
Is it because, like you said, the mass takes up space?
Potentially, but what is cancer? What does cancer do?
It's an abnormal growth of cells that grow rapidly.
Yeah, it grows rapidly. It's abnormal, so it's growing out of control. And so as it grows out of control, what does it need to grow?
Energy.
Energy. So it's using all the energy and nutrients that your body is supposed to be using for the rest of your organs, but it's eating up all that energy, all that nutrients to grow faster. And so the rest of your body is going to be relatively starved. And so it's going to require energy from other sources. And so you're going to break down fats. You're going to break down other stores within your body. So you're going to start losing weight. And so that's generally how cancer will make you lose weight. And even though if you're eating normally, it can make you lose weight. So good. All right. So Dr. Fatima, he has had difficulty swallowing food, or he has not had difficulty swallowing food or water. Why is that important to know?
I think that's important to know because he can't keep anything down in his stomach. That means.
Okay. So you're saying that he can't keep it down in his stomach? Sorry, I didn't quite get what you said.
Yeah, I think it's important because that might have to do something with his esophagus or or maybe it could be due to his abdominal pain. He couldn't keep anything down. It could help locate what's wrong with him.
Yeah, so if he was not able to keep food down, he's eating, he's having difficulty swallowing, it can definitely point to an esophageal problem. So the esophagus transverses from the back of your mouth all the way down to your abdomen to where it hits your stomach. And so the way the esophagus works is it contracts at right above where the food is. And so if this is your food right here, it'll contract and your food will be pushed down, contract, push down, because it causes that peristalsis going down. So there's two ways that you can have difficulty swallowing for the most part. One is going to be that the nerves innervating the esophagus just aren't working, so you don't have that squeeze to push the food down. The other is an obstruction. So you're squeezing. You're not able to push that food down because there's something obstructing. It can't get past whatever that is. So if that's a mass, you're thinking something like cancer, having the sensation that you can't swallow or food's getting stuck in your throat is important to know, because you can be dealing with something like esophageal cancer. And the esophagus connects down to the abdomen, so it might be there too. So good. So we'll stick with you. So but what's bothering the patient the most is this fatigue that's progressive. And over the last month, he hasn't been able to keep up with his daily routine. He's a construction worker, and it's been very difficult to get through his day, and he is not able to, he has to rest every hour. So why is that important to know?
I think it's important to know because it depends like where the fatigue like comes from. Since he's been working in construction, he's used to more like a faster lifestyle. So it definitely shows there's a problem somewhere there, I think.
Yeah, so if he's working construction, that means that he's doing heavy lifting. He's has a very physical job. And if you have a very physical job, you're going to have to be working for more than an hour at a time. And so it's strange that he's not able to do that anymore. So that tells us that there's something definitely going wrong with him. And the fatigue is progressing, which means that something is getting worse. So good. Now, I also say that he has significant dizziness. Well, let's go with Dr. Lillian. He has significant dizziness when he gets up too quickly, and it's made his work more difficult. So what does that tell you?
Probably he's not getting enough oxygen to his brain, which is why he gets dizzy when he gets up really fast.
Okay, so how does that work?
So when you get up really fast, the gravity pulls blood down, and so it probably doesn't have enough blood volume to perfuse his brain.
Yeah,
which is why he's getting dizzy.
Yeah, so as we get up, gravity starts working on our bodies more, and so all the blood that's supposed to be returning to the heart drops down and goes towards the legs. And so as you are trying to get up, especially, and you guys have probably felt it, where you stand up too quickly, your body doesn't have time to compensate for that, and doesn't have time to push that blood back up to the heart to be able to push to the rest of the body. And so the thing that I want you guys to remember with all of this is your cardiac output, meaning what your heart is putting out, is a function of heart rate and stroke volume. And so your cardiac output is what your body is kind of monitoring with your blood pressure and all that, but it's what it wants to maintain at a certain level. So if you have less volume for your heart to pump out, your stroke volume is less, it's going to compensate by increasing your heart rate. And so for all of us, when we stand up, our heart rates will generally increase to a certain degree. We don't feel palpitations or anything like that, but it will increase to compensate for that decrease in return. And then eventually, you're as you move around, you'll have blood flow coming back. But in the meantime, your heart rate's beating a little bit faster. And so for him, he's getting up too fast, and all of his blood is coming down. And even though, let's say his heart rate is going pretty fast, that's still not enough to compensate, meaning that there might be something going on with the overall volume. So whenever we talk about like dizziness, I want you to think of it in those terms. So it's going to be either the volume is an issue, or the ability for your heart to compensate is going to be an issue. Good. Dr. Lena is saying maybe his medicine. You want to talk about that a little bit more?
Yeah, so his medicine, I don't know if I'm going to pronounce it right, linsineprol. Basically, it's like for his high blood pressure, I think, or hypertension. And like it's used to lower his blood pressure. So maybe maybe it's getting like too low, like maybe he's taking like too much of it or something like that.
Yeah,
could,
exactly.
Cause that.
Yeah, so you have a blood pressure medication that if he's taking too much of it, will cause his blood pressure to go low. So it's going to be important to ask him how much he's taking, right? So let's say he's taking it the normal amount. He's been fine this whole time. If we admit him to the hospital, what are you going to do with that medication?
Maybe like not use it and see what happens,
Yeah.
I guess.
Yeah, we're going to stop it and make sure that we're not bringing his blood pressure even lower. It depends on what his blood pressure is, but yeah, typically we're going to stop it. Good job. So we'll stick with you. He's been having back pain for the last 2 months. It's more notable in the left mid back. It's a deep ache and nothing makes it better. And then, so we'll stick with that. So what are you thinking about with that?
Well, definitely like back pain to me kind of signals it's something wrong with his kidneys, because that's like usually where you get that kind of pain. And then like, especially like there's something, I forget, but it's like in his, I'm not sure if we go like down to the labs and stuff yet, but like with the bun, I don't know if that's how you say it, BUN. It's kind of, it's like really high, because I think it's like the upper is like 20.
Yeah.
And like he has 40, and so that's kind of like, I don't know, it's like a warning bell to be like, there's something wrong.
Yeah, that can definitely mean that something is wrong. But okay, so you said that when you have back pain, that means that something's wrong with your kidneys. What if I said that you had back pain like near your on the lower back, like right above your waist? Would that still make it kidneys?
Your lower back on your waist? Like, would that be like a spinal thing?
So that's the question. So if we're saying that back pain is typically caused by kidney injury, does it always have to be kidney injury?
No.
Or does it depend on where the back pain is?
Yeah, it depends where it is.
It depends on where it is. So
it could just be like posture or something.
It could be just posture. So the back pain can be caused by the kidneys, but it can also be just musculoskeletal, right?
Yeah.
Okay, good. So all right. So you're saying that potential kidney issues. In the next section, I'm saying that he's having blood in the urine, which he attributed to a UTI because he had symptoms like that in the past. And so he's drinking cranberry juice for a possible infection. So what do you think about that?
I think later, like it says that like if he had like if it was like a UTI or something, like it would. Sorry, 1 second. I have it written down somewhere.
It's okay. So Dr. Phillips is saying, could a UTI make kidneys worse if not treated? Yeah, it definitely can. It can be.
I feel like if I'm sorry.
No, it's okay.
Like it could be also like another symptom of like a kidney stone or something, because like you can still have blood in your urine if you had like a kidney stone.
Yeah, it could be. It can definitely be like a kidney stone, and that can definitely cause blood in the urine too. So good. So it can be a kidney stone. It can be something like a urine infection. It can be a lot of different things. Okay, good job, Dr. Andres Rodriguez. He's had dark, sticky stools over the last week. What do you attribute that to?
Can you repeat the question? It cut off a little bit.
Yeah, so he has dark, sticky stools over the last week. What does that signal to you?
Maybe like some kind of like infection going on within like somewhere in in the colon.
Potentially. So when we have dark, sticky stools, what makes your stools dark and sticky?
I was thinking back to like when you were talking about the like blood getting into, that's for the vomit. I was thinking something along the same lines as that, when the blood got into the stomach, that the other way.
I
would say, but the other way for like the colon and turn into being the stool like that.
Yeah, so that's a really good thought. The vomit that's dark and kind of like coffee ground looking, a lot of times that's because of the red blood cells that are in your blood. they get broken down, oxidized, and it causes kind of that seedy type of look. But as instead of going up and vomiting, if it instead goes down, but it had time to mix with the acid, it becomes dark and sticky because it's still mixed with stool and all that. And so it becomes kind of like tar. So we call it like black tarry stools. And so this might be an indication of upper GI bleed that's going down instead of coming up.
Okay.
So like a bleed in the stomach, in the duodenum, in the esophagus, something like that. Does that make sense?
Yeah.
Good. Dr. Krupp is saying, I think there's a possibility of diverticulitis due to the stool. Diverticulitis and diverticulosis would typically cause more bright red blood because it's lower in the GI tract. It's in the colon. So there's not time for it to actually mix with the acid from the stomach. But that is a good thought. Okay. So, good. And so he denies, so Dr. Rodriguez, so he denies fevers, chills, night sweats, vomiting, bright red blood in the stool, constipation, diarrhea, reflux symptoms, chest pain, shortness of breath. So with the fever and chills, what does that tell you? Dr. Rodriguez?
Can you repeat that one again? I'm sorry,
Yes.
it keeps going out.
Okay, so if he has no fevers and chills, what is that less likely to be?
No fever, chills would be, less likely to be. Looking at my notes real quick.
I think that they're helping you out in the chat too, if that's helpful.
For some reason, I can't see the chat.
Oh, it's okay. So it's less likely an infection, right? So,
Okay.
So yeah, and then we talked about bright red blood in the stool. If it was a lower GI bleed, it would be more bright red. Good. Okay. So Dr. Tarun, anything else in the history that you want to know about? Dr. Torres, anything in the history?
Oh, sorry. My
That's okay.
mic is
It's okay.
muted.
It's okay.
Whether like he's having issues urinating, I guess.
Yeah, so if he's having like burning with urination, that can tell us like he might have a UTI. He doesn't. Anything else?
Also, like if you like can check if he's having any other pain in the abdominal area or tenderness.
Yeah, so when we do a physical exam, we can definitely check that. In like the actual like his medical history, like the social history, he has a 30-pack of smoking history. I tried other drugs, but that was a long time ago. And then his alcohol intake isn't really that high. Okay, so let's go with the vitals. So his blood pressure is 110/66. His heart rate is 110. Respiratory rate is 16. Temp is 99, and O2 sat is 96 on room air. Anything stick out to you, Dr. Tarun?
I think everything is kind of normal. Like the BP can be explained by the medication.
Okay. What about the heart rate?
I mean, it's a bit elevated. Like normal heart rate is like around 60 to 100.
Yeah, so his heart rate's high, so he's tachycardic. Anything else stick out to you?
Only in the vitals or anything else?
Yeah, in the vitals.
No, everything else kind of seems normal.
What about the blood pressure?
It can be explained by the medication, I thought.
Yeah, so it depends. So we have to know what his baseline is. So if his baseline blood pressure, even with the medications, is like 130 to 140 or even higher than that, then this is low for him. But if his blood pressure is around 110 to 120, then that's about normal for him. So it all depends on what his average is. I think this is a little low for him, if I remember right. I forgot to write it down, but yeah. So with the heart rate being 110, why do you think it's 110? Why do you think it's elevated?
Because I mean, I remember like he said like he was getting like really fatigued easily. So maybe like it has something to do with that.
Yeah, potentially. Dr. I'm going to mispronounce your name. I apologize. Lakeitha? So what do we think about the heart rate? And tell me if that was the right way of saying your name.
Yeah, that was the right way.
Okay.
Yeah, so I just thought since his blood pressure seems to be abnormally low, it's probably making up for the low stroke volume by increasing the heart rate to maintain the same cardiac output. And also, like we were talking before, it might also be related to like the fact that he's like dizzy too. So
Yeah.
it might be related to that. So like since blood flow's not getting up to his brain as well, the heart rate's probably trying to fix that.
Yeah, so overall, what would that mean in terms of his overall volume? Is it going to be high, low?
Well, since the actual stroke volume's low and the heart rate's trying to balance that, would it just be normal? Or
So-
is it?
Yeah, so that it's kind of a difficult question based off the wording. So his overall volume in his body. So if which is kind of a function of the stroke volume. So if he has low volume in the body, either because he's dehydrated, because he's bleeding, his heart rate's going to try to compensate for a longer period of time to try to keep up that cardiac output, because there's less volume to push out of the heart because it's going somewhere else, right? He either doesn't have enough because he's not drinking enough, or he's bleeding out somewhere. So that's why tachycardia can be a sign of hypovolemia, low volume.
Okay.
Yeah, does that make sense?
Yeah, thank you.
Yeah. And so other people are saying maybe it's because he's at the doctor's. Potentially, people do get nervous around us. So it's potentially a problem, but he has other signs that point to something else. So you don't want to just say that it's because he's nervous. Good. All right. So we'll stick with you. Anything in the physical exam you want to take a look at first?
I went to the abdomen first, and the tenderness in the epigastric region probably signifies something that's wrong there.
Okay. So good. So he has tenderness in the epigastric region, which means that something in that area, so the stomach, the liver, the gallbladder, maybe even the spleen, something's going on in there. He has no rebound or guarding. So what does that mean?
I'm not sure.
So good. So rebound and guarding are signs of basically irritation in that area. So all of your intestines and all the organs in the abdominal cavity are kind of lined with this peritoneum. It's basically aligning that the omentum and the peritoneum basically grab all the junk inside the belly, kind of filter it out, bring it back. And so it's important. It's an important system to be able to determine if there's things inside the belly that are not supposed to be, like stool. So if you have a bowel perforation, that's going to get irritated, like blood, and just fluid in general. So if you have like ascites, that can cause that becomes infected, that can cause some peritonitis. So so that it's just basically a covering of the entire abdomen. So rebound is when you push down on the abdomen and you let go, and as you let go, that causes pain in the abdomen. And it causes pain because it kind of causes a movement type wave around the abdomen. So you're pushing down and letting go really quickly. That movement's going to dissipate throughout. And if you have any area in the abdomen that's affected because of perforation, blood, whatever it is, it's going to cause irritation there. So rebound is, guarding is where your own abdominal muscles are kind of tensed up because of some type of inflammation that could that basically. It's your body's way of protecting your abdominal cavity. And so you push down, you feel like it's like rock hard or rigid. That's a bad sign. That means that there's a lot of inflammation down there. And especially if it's not voluntary, if you push down and your patient's like not trying to contract his muscles, you're saying relax, but those muscles are super, super hard. That tells us that there's a lot of inflammation down there and you want to call a surgeon. So these are all signs of like something serious, like a bowel perforation or a bleed or something along those lines. So, so good. And bowel sounds in all four quadrants tells us that his bowels are moving. And then suprapubic tenderness. Do you know what that tells us?
I'm guessing that's that's like right above the pubic region, right? So I think that if there's no suprapubic tenderness there, then it's nothing wrong with like any of the reproductive organs or the lower like large intestine, colon and stuff. So you can definitely just focus up near the stomach.
Yeah, it's more most of the time we check and we see if there's like a bladder infection, because when you push down in that area, the bladder's right there. So if you were to push down in that area and you kind of needed to pee, it's going to make you want to go pee more, because that's where the bladder is. So if you have an infection, it can be tender because the bladder is inflamed. You're right. There are other organs in that area, so you can get irritation there from those other organs, but it's mostly the bladder.
Okay.
Okay, good. So, all right. So Dr. Shah is saying a general exam first. So he's well groomed and pleasant. Overall appears underweight though, but not in any distress. And that's an important point, Dr. Shah, because the first thing that we typically do when we go to see a patient is kind of see what their overall status is. If they look really sick, you're going to have to intervene quickly. But if they're like sitting there comfortably talking to you, then you have a little bit more time. Okay. Dr. Shah, anything else in the physical exam you want to get?
In the physical, I was looking at the CV, and
so
the cap refill kind of stuck out to me, because I saw that the range, it was towards the high range of that.
Okay. So what does that tell you?
I know that there are perfusion issues, so maybe we have to give him some fluids to maintain that perfusion.
Yeah, so there might be some perfusion issues. You want to get some fluids. The cap refill, 3 seconds. Some people will say that's kind of on the upper limit of normal. For me, for a young person, generally I would say that's probably a little bit too prolonged, and so I would think that there is an issue
right.
with refill. So good, and he's tachycardic as well.
Right. The CVA also stuck out to me.
Okay, what about it?
Because I know that if you have a back CVA tenderness, that means that there is a potential kidney stone.
Yeah. So what is CVA tenderness? What are you doing with CVA tenderness?
I actually searched this up. I think you basically put your hand on the patient's back and then tap, and they would react if there's some sort of problem or infection.
Yeah, so what I do, I put my hand on the back, basically right where that kidney area is, and I actually tap pretty hard, right? Mm-hmm. So I'm hitting them. And so if there's significant tenderness, they'll jump up. If they have a kidney stone, if they have a kidney infection, they will jump up in pain. For this patient, it was positive because he was like saying ow, 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 but it wasn't like that jumping up where he's like, he's telling you to stop, or he's like getting off the table. So we know that there's something maybe going on in that area on the left. Good. Dr. Carlson, anything else you want to get?
Yeah, so I said that you want to do a rectal exam just because to verify that there actually was a black tarry stool. Because it could be a GI bleed.
Yeah, so what do you do with the rectal exam?
Normally it ends up like you actually have to like collect a stool sample yourself. Mm-hmm. So normally like actually like collecting stool from the rectum.
Yep. You put your finger in there, you get some stool, you put it on this little card. You wipe the stool on the card, and then you put this solution on it. And if it turns bright blue, there's heme products in there. There's blood there. Right. So yeah, rectal exam. There's this adage in the ER. It's like the only time that you don't do a rectal exam is if you don't have a finger and they don't have an anus or something like that. So you should always do it, especially if you're suspecting a bleed. And so I had a patient where they were just fatigued. It was a different patient, and everything looked fine, but their symptoms seemed off. And I did a rectal exam, and it was positive. Turns out he had a pretty massive bleed. He was just compensating really well. So we had to get labs and all that. And his hemoglobin was pretty low. So good. All right. So in this patient, the rectal exam was positive. So it looks like there is blood there. So we'll stick with you. What labs do you want to get?
So I would definitely I would want to get a white blood cell count, but I would also definitely want to check for obviously like you got the CR and the BUN on there that told us about the kidney a little bit. And then also check his hemoglobin due to the blood being in the stool.
Good. So he has bleeding in his stool. So you want to get a hemoglobin. His hemoglobin 7.2. Is that normal?
Low. It's low.
It's low. It's pretty low. It's actually really low. So that can explain a lot of his symptoms. You mentioned a white blood cell count, and that was the first thing you mentioned. Why? What are you looking for?
Just to verify, along with the fever and everything, to verify that there's not infection. Also to verify inflammation could kind of help explain some of that tenderness in the abdomen. So just to make sure that there's not any inflammation there.
Yeah. So if he has tenderness in the abdomen, he has a elevated white count. You're gonna want to think of something like an intra-abdominal infection. Good. And then you had mentioned the BUN creatinine. I think did we talk about that already?
I think we did a little bit, just talking about how if it's high, that it's going to indicate kidney issues.
Yeah. So his creatinine's 1.8 and his baseline's 0.7. So what type of kidney injury do you think this is?
It could be a pre-renal. Is normally the most common, but there's some type of blockage somewhere in the kidney.
Okay. So is it blockage in the kidney?
Or pre-renal would be beforehand, but
yeah. So pre-renal means before. So if you have your kidney here, there's something that's inhibiting the blood flow from getting to the kidney. So that's pre-renal. What are the other two kinds of kidney injury?
Post-renal, and then I can't remember what the one literally like in the kidney.
Okay. So what is it's intrinsic renal? So
yeah.
So what is post-renal? Like what typically causes post-renal kidney injury?
Would it be anything like the ureters? Anything that's going to be literally post the kidney, so a blockage there. It could be a kidney stone that's stuck in your ureter, would then cause backup and infection.
Good. What about in a 78-year-old male? What's the most common cause of post-renal kidney injury?
I have no idea.
Okay. What do old men typically have? They end up urinating a lot because of it.
I'm looking in the chat. It said prostate cancer was one of them, but it could be anything with the prostate.
Yeah, anything with the prostate. Not necessarily cancer, although they can have cancer for sure, but benign prostatic hypertrophy. So that prostate just gets bigger and it closes up the outflow tract, and that can cause a post-renal injury. Good. And the last one you said intrinsic renal. The intrinsic renal typically is a lot of times I see it's probably because of medication they're on or like contrast that was given. So good job. All right. Dr. Bella, what about the BUN?
The BUN, let's see. The BUN was high, I believe.
Uh-huh. So
and then, oh yeah. Oh, I'm not really sure what that test was.
So it's a breakdown product that's filtered out by the kidney, and so it also tells us that there might be a kidney issue. But there's something specific with GI bleeds and BUN. Do you know what that is?
Is it the nitrogen levels in the urea?
Yeah. So blood urea nitrogen. Basically, as the red blood cells get broken down, they release this byproduct that gets absorbed back into the blood. So if you're having a GI bleed and you're breaking down that blood as it goes through and you're reabsorbing it, you're going to have a higher BUN in blood as compared to normal. And so a high BUN in comparison to the creatinine can tell us GI bleed. So the ratio that we typically look for is 20-1, and I think this patient has a little bit higher than that. So good job. So that can indicate a GI bleed. Any other labs you want?
Yes. So we went through the creatinine. Oh, the urine dipstick.
Okay. So
and there was it was positive for blood, and the specific gravity was 1.03.
Okay, so what does that tell us?
That there was high levels of blood in the urine.
So so there's blood in the urine. We don't know how much it is because I didn't give you like 2+ or 3+ blood or whatever. You would typically get a UA to confirm that. But what about the specific gravity? What does that tell you?
The urine is highly concentrated, so he might be dehydrated.
Good. So it looks like he's dehydrated potentially with that high specific gravity. All right. So I want you to give me your overall assessment. What do you think is going on with this patient?
So I thought, me and my group believed that the patient might be going through kidney failure, and this could be due to an obstruction in the ureter, and that could be what's causing the nausea, the difficulty eating even, and then the blood in the urine would also have to do with obstruction. And also the black tarry stools, and especially the CVA tenderness and the pain in the back. So we linked all of that kind of to kidney problems. And then we had also that drug interaction also exacerbates all of these symptoms, like the fatigue and the dizziness also attribute to that.
Good. I agree with everything you say except for the black tarry stools. What does the black tarry stools tell us?
The black tarry stools, so we also had that for potential issues with the stomach, like a peptic ulcer, and also because of the eating problems. Maybe he's not getting enough nutrients that he should be getting.
Okay. Yeah. So we have a bleed in the urine, blood in the urine, and blood in the stool. So it is difficult to try to correlate those two. Can you think of any reason why something that would cause both of those issues to happen?
So it looks like there could also be issues with cancer. For example, stomach cancer, and then it looks like cancer that's metastasized.
Yeah, good. So that's kind of the what I want you guys to do. So you have all of those symptoms that we figure out with the case. You rank the things that are likely. You guys thought that maybe there was obstruction, the kidney injury, and the blood in the urine and all that. But then you have this question of, wait, if it's just the kidneys, then why is there blood in the stool? And then so you want to see, one, they can be completely unrelated, but most of the time, well, actually, I wouldn't say most of the time. A lot of the time, they won't be if it's like super coincidental. You can have unrelated issues. People, everybody's an individual, so maybe. But I want you to be thinking like, okay, what fits and what doesn't. So very, very, very good. All right, Dr. Wall, you're saying cancer that's metastasized. So what do you think is the most likely cause of this patient's symptoms?
At first, I was thinking mostly kidney cancer.
Okay.
Because I wasn't sure what the stool meant, the black sticky stool.
Okay.
So my guess would be kidney cancer that metastasized to possibly the stomach or the upper GI area.
Okay. So what do you want to do to confirm your diagnosis?
I think a CT.
Okay. Let's get a CT. Do you want to do it with contrast or without contrast?
I don't know.
Okay. So people are saying without contrast. Can you think of why?
Maybe the contrast would be more pinpointed towards vascular issues.
It can, and you are right that the contrast lights up the vasculature. But we use contrast a lot for the way that I remember it is contrast is for infections and malignancies. If I am thinking of either of those, I always want to use contrast. So cancer or infection. And you're right, when you do an angiogram, you want to light up the vessels and see if there's narrowing anywhere, definitely that too. But why can't we do it in this patient?
I'm not sure. Oh, because of the kidney issues, because of the kidneys not functioning properly.
Exactly. So if we give contrast to this patient with an already acute kidney injury, so they have some type of injury to the kidney, we give them contrast, that can worsen it and put them into renal failure. So we can't do contrast. So we got a CT abdomen, chest, abdomen, pelvis without contrast. It was limited due to the lack of contrast, but they saw a 3-centimeter mass in the antral portion of the stomach. So in the end part of the stomach, kind of where it transitions to the duodenum and into the small bowel, they saw a 3-centimeter mass. And then they also saw a 5.5 centimeter irregular solid structure in the upper pole of the left kidney. So you have two issues going on now with that CT scan. So you have two different masses, one in the stomach, one in the kidney. What do you want to do?
Biopsy.
Okay, which one?
I guess the kidney because it's larger, but I'm not sure.
Okay, potentially. So Dr. Sukla, what do you want to do? Do you agree? Do you want to do the kidney?
Sorry, can you hear me?
Yeah, I can hear you.
Oh, okay. Sorry about that. I would say a kidney biopsy so we can take some of the mass and see if there is a malignancy.
Yeah, so we typically want to do the one that's a little bit bigger. A lot of times it's the primary, though that's not always the case.
Right.
But this
Would we do the
patient is
left?
bleeding. And she's bleeding, he's bleeding through the stomach, and he has bright red blood. So what is something that we can do to stop that bleeding?
Can we do EDG?
Yeah, we can do EGD.
Sorry, EGD.
Yeah, we can do an EGD, and when we do an EGD, what can we do?
Is there a way we can maybe get rid of the mass?
But not so much get rid of it, because that would probably require actual surgery. But we can get to the mass, and if we get to the mass with just a scope down the throat, what can we do?
Would we like burn it off? Stop the growth somehow?
We stop the bleeding, so wherever it's oozing, we can stop it. But we can also get a biopsy of it. So
right.
That's a lot easier to get to than going through the back to get a kidney biopsy.
To the kidney, gotcha.
And so it's a little less invasive, and it can also treat the bleeding from the stomach. And so this patient had an EGD, and it showed an ulcerated mass in the antrum of the stomach with notable oozing. So it's just oozing blood. Not so fast where it's going to be causing you to be nauseous and throw up, but it's oozing blood. So biopsy was taken, and argon plasma coagulation was used for hemostasis. So they took a biopsy, they clotted it off, so it's not bleeding anymore, and then they were done. So you want to keep this patient here in the hospital? Do you want to send him home? What do you want to do?
I would send them home.
Okay.
Because I think hospital tend to cause infection a lot more. So I would try to keep him sanitized, prevent that.
Okay, so we send him home, but he has a hemoglobin 7.2.
Right. Oh, would we give him a blood transfusion too?
Yeah, so we're going to transfuse some blood, and we're going to want to hydrate him because he's dehydrated. So we'd probably keep him overnight. Are we going to wait for that biopsy result?
We would, right?
We would, but if he's ready and stable to go, we'd probably just let him go home and just follow up after that. So good job.
Perfect.
All right.
Thank you.
So the biopsy returned as clear cell renal cell carcinoma. So it was a kidney cancer that was metastatic to the stomach. He was referred to hem-onc and started on monoclonal antibody therapy. He required multiple hospitalizations for the GI bleed and to control the bleeding from the abdominal mass, and he required multiple transfusions. And so because he had both masses, the one in the kidney and the one in the stomach, we can't do surgery on him because it's not going to help. He already has two pretty significant masses. So what is something that we're going to want to do before we even give treatment? Anybody can answer this. So what are we going to want to do to figure out what treatment to give him? Anybody can answer. Dr. Romy, do you want to answer?
Would you do a scan?
What was that?
Would you do a scan to figure out which mass has progressed further?
So we know he has metastatic cancer, so we're going to want to know the extent of it. So we would I would do a CT scan. I would wait for his kidneys to get better. I'd give him hydration, give him blood, all that stuff. And once his kidneys get better, I would do a CT scan with contrast to see, where the masses is. Dr. Walsh is saying a PET scan, and we can do a PET scan. They're typically more expensive, and a lot of times we use PET scans more for surveillance and seeing if there's recurrence of a mass after it's treated. So I would probably do a CT scan and see the extent of it. And so for this patient, he had metastatic cancer. It was causing bleeding in both areas. But with renal cell, a lot of the times it's silent until it causes other issues down the line. And so and it's usually involving metastasis. And so it wasn't until it metastasized to the stomach that he started having symptoms. Maybe that bleeding that he had before in the urine was the cancer. We don't know, because he did have signs of a UTI at that time. So, I mean, there was no fault in treating for the UTI because that was more likely. And so that's the hard part with renal cell. And in general, with abdominal pain, you guys can now see why it can be very difficult, right? There's a lot of things going on in the area, and you have to kind of tease out these little clues in the history and in the physical and in the labs to kind of pinpoint what it is that's going on with this patient. Dr. Krupa saying, why not an MRI? MRIs are typically more expensive. They're very long, and any movement can worsen your image quality. So we prefer a CT scan because with contrast, because it can give us what we're looking for. I just did a report on CT scans. I researched that multiple CT scans lead to higher risk of cancer because of radiation, and if so, will that affect him since he's already has cancer? So a lot of times at risk is when you're younger, because when you're like a kid, that's why we don't really do CT scans in kids. You give radiation to the kid, you can cause potential mutations that will show itself over a long period of time. 1 or 2 CT scans won't cause any mutations. If you do sequential CT scans like monthly, it can cause radiation injuries and cause possible mutations. How do you know how many tests to do without costing him too much, but also know what's wrong? So that's a really good question, because you have to, you never want to go in and just do all the tests just because you don't know what's going on. It's better to ask a colleague and try to figure it out. Whenever you order a test, you have to know what it is that you're trying to get out of that test. And so it's going to be important to ask yourself, what is the importance of this test every time I order it? So if you need to order more tests, that's okay. Just make sure you have a reason behind it. Yeah, it's not a great answer, but that's honestly what we do. Just ask why and ask what we're trying to get out of it. Was a kidney biopsy given because it was more prominent than the other symptoms going towards the stomach? No, we actually did the stomach biopsy. We didn't do a kidney biopsy. And the stomach biopsy told us it was renal cell, which told us it was a metastasis. That was the easiest one to get out of. What's the significance of the chloride test? So chloride, there's a lot of, chloride is something that we typically don't really look at. There's a lot of issues that can show up as like hypo or hyperchloremia. You can see it derangements in chloride with alkalosis from like vomiting and stuff like that. It's not straightforward, and honestly, a lot of people don't really look at the chloride. I can send you more information though, if you want. Should we get blood tests to look for H. pylori? You can, but we already have a reason why this guy is bleeding, so I probably wouldn't. It would just be a waste of resources at that time. All right, so I have to go to make sure that I get out on time with the last class. But if you have any more questions, I will try to send a survey out to see if you guys want to talk about this more once you have more time to digest the case and think about it a bit more. So I hope you guys enjoyed this case, and we will talk soon. Okay, thanks. Bye.